So to start us off with, who are users of digital adherence technologies? On the one hand, you can consider the person with TB. So that's the person who has the technology in hand and who's taking their medication on a daily basis. So basically, they interact with their adherence monitoring device to be able to record their medication ingestion. And this could be at the same time of taking their medication or afterwards. So, and then you also have the healthcare provider on the other end who does or accesses the adherence platform on a daily basis to monitor the adherence of persons under their care. And they provide additional follow-up support for people who are having a hard time with maintaining optimal levels of adherence for their medication. So when you go about designing an intervention or designing the digital adherence technology intervention in a person-centered way, this impacts the level of uptake. And to be able to take a person-centered design approach, you need to make sure that the intervention is relevant for both of these groups of users, and it needs to add value for both of those groups. So in other words, you need to make sure that the intervention is tailored to the population that you're wanting to target, as well as the context in which you are implementing digital adherence technologies. So what are some of the considerations when you're going about designing the intervention for the person with TB? So this is the person who has the technology in their hand. So that could be the smart pill box that they're using, it could be video supported treatment, or it could be the medication label or sleeve. And I'll leave my colleagues to provide a little bit more insight into each of these technologies. But basically, when you're going about planning this intervention as a program, you need to be clear what some of the reasons are associated with providing this intervention to people on treatment. And what we've seen as the Global DAT Task Force is that the benefit primarily lies in being able to provide follow-up support for people. So it's not just about the actual technology that they have in hand, but it's what the technology means, or it's the data that it generates for the healthcare system to provide follow-up support and ultimately improve their adherence. Then also when you're going about planning this intervention, whichever technology you select, you need to make sure that the benefits of it outweigh some of the risks that are associated with this technology. For example, we know that TB is a very stigmatized disease. And so when somebody needs to take a video on a daily basis, this could attract attention from people within their communities or families that they're not necessarily wanting to inform that they have TB. Then you also need to make sure that whichever technology you're selecting is relevant as well as acceptable for the person's circumstance. So if you compare two different technologies, the one being video supported treatment, you would need to make sure that you have a daily electricity supply. So maybe that's not relevant for populations in a more rural setting. Whereas the pill box, for example, this box only needs to be charged once every few months. And so that would be more relevant for certain population group settings. Then when you're actually rolling out this intervention, you need to make sure that the people that are using it know what this is about. They need to receive sufficient information. So what is the technology? How does it work? What is some of their data being used for? And what is the ultimate benefit of this technology for them completing their treatment? Then the next point is rather obvious, but it is a really important one. You need to make sure that the technology actually works. So if it's not working sufficiently, and I'm going to allow my colleagues from South Africa to provide more insight into the technology actually working. But if it's not working sufficiently, it can lead to a high level of frustration and over time, less engagement with the technology. And then lastly, you need to make sure that the people who are using this technology and who are taking their medication on a daily basis actually feel that their adherence matters. It's not just another number, but the fact that they are taking the medication on a daily basis matters. And they also need to feel that if they're sending this data through every day, that they actually have a connection with their healthcare provider, that they're not just sending their data into this abyss without any follow-up if they're needing this follow-up. So then let's move on to considerations when designing the intervention for a healthcare provider. And here you also, similar to the person on treatment, you need to be clear what the reasons are behind your intervention before you begin designing it. And what we've seen in terms of this intervention is that the benefit lies in reducing workload for persons on treatment, for healthcare providers. And it also ensures that they have a far smoother workflow. And then additionally, it means that they're able to support people optimally to successfully complete their treatment. So when you go about designing the actual intervention to benefit healthcare providers, firstly, you need to make sure that you are taking a co-creation approach. So you would conduct workshops with a select number of healthcare providers to have an understanding of how you might design this intervention to benefit their workflow and their context. And then once you have actually begun implementing, you need to make sure that you have regular feedback moments from them to understand what is working and what isn't working. And based on that feedback, you need to iterate your intervention. Then additionally, you need to make sure that the intervention is sufficiently integrated into a healthcare provider's workflow so that it doesn't feel like an additional burden to an already overloaded task list for healthcare providers, but that it streams well into what they're already doing on a daily basis to support their people or the people under their care. And then similar to people with TB, you also need to make sure that healthcare providers receive sufficient training. So this includes also understanding how the technology works. So for a healthcare provider, understanding what happens when a patient sends through their adherence data, how the actual adherence platform works. They also need to have a good understanding of what the impact is of this technology on people under their care, as well as the benefits both to themselves as healthcare providers as well as to people on treatment. And then lastly, they need to have a good understanding of the workflow associated with rolling out this intervention. For example, if a person on treatment is not sending through their adherence data, they need to have a good understanding of what processes to follow so that they can provide optimal support for people on treatment. And then lastly, similar with patient and very obvious, but a very important one to state is that the technology needs to work. So a healthcare provider needs to be able to log onto the adherence platform on a daily basis without the server being down, for example, or without interruptions to internet connection or to electricity supply, because this also impacts their engagement with the technology over time. So that is my brief introduction of user engagement. And so from here, I would like to hand over to Nonto Ndlovu. She is a senior program manager at the Aurum Institute in South Africa and has been leading the implementation of TB research since 2011. She is currently a PhD student at the University of Cape Town. And Nonto and her team are have trained more than 800 Department of Health TB staff to implement digital adherence technologies under the ASCENT project. Then following Nonto's presentation, she will hand over to Tanya Dube, also from Aurum Institute in South Africa. And she is a research manager at Aurum. And she's also a PhD candidate at Wits University. Tanya has extensive experience in implementing DATs among people with DSTB as well as RRTB.
Thank you very much for the introduction, Inez, and thanks everyone for joining us for another interesting webinar by the Digital Adherence Task Force. So to start, we'll be speaking about the DAT user engagement, and we'll be sharing our experiences from the ASCENT project implementation in South Africa. As Inez has already stated, my name is Ndlovu, and I'm with my colleague, Tanya Dube. And as Inez also has given a very good introduction to everything that will happen today, if you look at my first slide, okay, Inez, it looks like, okay, there we go. I have pictures there showing really who the end user is. And we see that we have the patient who is the end user, as well as the service provider, the nurses, the doctors. They are also the end users. So when we think of end user, we consider all the people who are engaging daily with the digital adherence technology. So I will just give the context and background of the state of TB in South Africa, and also give you a clear picture of what we set out to do under the pragmatic implementation of digital adherence technologies under the ASCENT project. And then Tanya will delve more into the user engagements. So the ASCENT project, the acronym, the full title is Adherence Support Coalition to End TB. And it is a project that was implemented by a consortium of partners that included the KNCV, PATH, the Aurum Institute, and the London School of Hygiene and Tropical Medicine. It is a project that started in July 2019 and ended in June 2023. The implementation phase was just 2 years. So the project was funded by UNITAID, which is an international organization investing in innovations to prevent, diagnose, and treat HIV, TB, and malaria more quickly, effectively, and affordably. All right, so just to give you a background of the status of TB in South Africa. So South Africa is one of the 10 countries with the highest TB burdens in the world, accounting for 2/3 of all TB infections globally. So South Africa is also on the 3 global lists of high burden countries for TB, HIV-associated TB. We've got almost 60% of our TB population being co-infected with HIV. And also we are on the list for drug-resistant TB. The WHO estimates that over 110,000 people in South Africa lost their lives between 2020 and 2021. And since 2010, over 1 million South Africans actually succumbed to TB. And this is very sad because we all know that TB is preventable and curable. So a lot still needs to be done, you know, to prevent all these unnecessary deaths. The treatment success rate is still low in South Africa, with it being 78% for drug-sensitive TB and 65% for drug-resistant TB. So that is still below the 90% target. And we know that the main contributor to these treatment fails is non-adherence to treatment, which leads to increased unfavorable outcomes, relapses, drug resistance, disease transmission, and also a heightened health systems costs. So we definitely need innovations to improve TB treatment adherence and optimize the use of new and existing tools to reach the global end TB goals. So the implementation of digital adherence technologies has the potential, you know, to be a big contributor in this regard. So our current NSP, which is the 5th NSP, which was launched last year, it will encompass, our steps forward between 2028 and 2023 and to 2028. It is our national strategic plan for HIV, TB, and STIs, and it's actually the country's roadmap to guide and inform the country's responses to HIV, TB, and STIs, and also guide the country towards ending and eliminating these public health threats by 2030. So it has 4 interlinked goals. So I just highlighted goal number 2 because it speaks to what we are busy implementing, which is digital adherence technologies. And the goal 2 speaks about maximizing equitable and equal access to HIV, TB, and STI services and solutions. And under goal 2, 4 speaks about strengthening support and increasing treatment completion for people with TB. And so specifically, as you go down under this goal, you see that our national TB program is really interested in adopting and scaling up the evidence-based digital adherence support technologies for people with TB. So it was very good that our country was then one of the countries who participated in the ASCENT project. So the ASCENT project was really one of the biggest evaluations of digital adherence technologies that has occurred thus far globally. And there were 5 countries which participated. Those were the Philippines, Ethiopia, Tanzania, South Africa, and the Ukraine. And under the ASCENT project, more than 7,000 digital adherence technologies were made available. And these technologies supported more than 10,000 patients across these countries, including a small amount also of drug-resistant TB patients. So the project set out to evaluate whether these technologies are effective, will they be acceptable to the end users, are they feasible to implement pragmatically, and also we looked at the cost effectiveness. The primary objective, the final goal for these evaluations was to come up with evidence that will give the national TB programs a scalable, affordable, evidence-based digital adherence technology that is formed by a person-centered treatment support package for TB. So the main 3 technologies that were evaluated under the ASCENT project was the 99 dots, the video-supported dots, as well as the smart pillbox. So as we went out to evaluate these technologies, we found that all countries ended up really mostly using the smart pillbox. As you see, the orange sections will be what each country actually ended up having, the number of patients who were on the smart pillbox. And we can see the variation across the countries that really it's not one size fits all for, all the countries. Some countries were able to actually have a lot of 99 dots as well as the smart pillbox. And some countries like South Africa, we ended up having to really do away with 99 dots. We couldn't really implement it in our country. We tried though, and we ended up having to go with the smart pillbox mostly. And as you can see that we did not even go into doing video supported dots because of the stigma, that is linked to having TB and people thinking that if they take a video of themselves, they might end up on social media. So all those evaluations went into place when we were implementing and finding the most suitable digital adherence technology for the different settings. So looking at the different technologies, we found that the platform that we used was really user-friendly to the end user. And this screen just shows, how the platform made the work of the healthcare provider much easier. As we can see, you have a screen that quickly just shows the healthcare provider which patients have missed a dose, and quickly just shows the healthcare provider, how the patients are doing. And also there's a screen where there was a task list. If the healthcare provider just wanted to see only patients who missed a dose yesterday, so they could just click on the tab and then see how many patients have missed a dose the previous day. And then we see also that the patient calendar was very, very clear. So really, with all these functionalities on the Everwell platform that make it easy for the nurse, to just spend 5 minutes in the morning, quickly just browsing through, okay, how are my patients doing? And seeing this graphically and easily really came in handy to ensure that, the healthcare providers are actually engaging with the platform on a daily basis. Okay. And choosing also a platform that can integrate or be interoperable with other platforms, that are compatible, helped us to even be able to produce data that can be looked at by, higher level staff who are not based at that facility, but maybe are responsible for the entire district. So the Tableau platform was, was interlinked with the Everwell platform that was used at the facilities. So we could generate this type of data where the higher level staff, the district managers were able to see how the entire district is actually performing in terms of adherence. And so people are able to then zoom in to the areas that need more support. As you see on this screen, we've got some small clinics down here who were not doing well at all in terms of adherence. The greener the clinic, it means the adherence and the use of the digital adherence technology is really good at that facility. So this really enabled, the end user to be able to just see exactly where they must direct support immediately. So on this screen, we could actually view 61 facilities that we're implementing in South Africa. Is more data that we could actually pull out graphically from the platform itself, where it shows the patient side, where we knew that for the DRTB component, the patients are expected to engage with the platform or with their digital adherence technology. At least we're expecting them to engage for 175 days. And for DSTB patients, we expected them to engage for 148 days. And we can see that on the DRTB, the average engagement was 132 days of engagement. And on DSTB, 127 out of the 148 days. So it translated to about 86% of engagement from the patient side with the digital adherence technology. And it is recorded digitally so that we can see that the patients are actually using their adherence technologies. So the better it is. So 86% was not bad at all. So with these, being cognizant and being sensitive to what feedback you are receiving from the end user and making, changes as you go along, resulted in the ASCENT project really having tools that were very easy for the nurses to implement, and also were very, very acceptable and appreciated by the patients themselves. So within South Africa, over the 2 years of implementation, we implemented in 3 provinces, the Northwest, Gauteng, and the Western Cape, where we were able to get 3,212 participants to be supported by our digital adherence technologies. And after the enrollment phase, we had one of the districts, Northwest, continuing totally outside the ASCENT project. And up to December last year, they had added another 500 patients to be supported. So this just leads me to my last slide, where I speak about the importance of a very solid foundation, a strong training on the staff who are going to be leading the implementation, or who will be implementing the digital adherence technologies. So the implementation in South Africa, we had KNCV come over and they gave training to just 4 of our staff members who would be the main implementers in the 3 provinces. So the training was very solid and really good. And these 4 people, that is Fezega, Nonto, Tanya, and myself, we were then able to transfer this training across the country, where we were then able to train 809 Department of Health staff to implement these technologies across all these districts that participated. So there's a big emphasis, on developing very good training tools and ensuring that, the trainings are done very well. And the teams on the sites are well equipped to implement the technologies, and also to train and give sufficient and relevant information to the participants or patients. So I will pause there and hand over to my colleague Tanya to take us into what we found. Thank you. Please go ahead, Tanya.
Thank you, Nonto. As my colleague Nonto has said, I will be speaking about the barriers and facilitators to DAT engagement based on South Africa's experiences. So firstly, picking up on Nonto's point, I would like to emphasize the importance of adequate training as a key facilitator for DAT engagement. So as Nonto showed, ASCENT invested a lot of time and resources to train over 800 healthcare workers across 3 provinces and 5 districts in South Africa. So the importance of the training is that it makes healthcare workers understand the purpose of the digital adherence technology and what the adherence data they view is for. And secondly, it's to build their capacity so they can be able to provide people with TB with adequate information when implementing the DATs. So in South Africa, we mostly conducted in-person trainings, and these were in smaller groups. So we would group 3 or 4 facilities based on their availability. So this was important because it encouraged participation, and they were able to ask any questions if there was something not clear. And it also allowed us to provide them with sufficient support during the practical session, so they would confidently leave the training rooms ready to start the implementation. So we also did a couple of online trainings, because these trainings were done during the COVID period. And because of travel restrictions, we had to start training online. And we found that some healthcare workers were multitasking, so they didn't get much of the training. And when the travel bans were lifted, we had to travel and train them face-to-face, which we found beneficial. And over and above these mass trainings, we found on-site refresher trainings important, especially when the healthcare workers started implementation. This was to motivate them and just to remind them, if they had forgotten anything from the main training, to just build their confidence and run with the project. So trained healthcare workers were now able to provide people with TB with adequate knowledge. So I'll start with facilitators for user engagement for the labels among people with TB. So a label was a version of the 99 dots, where there was a sticker on a blister pack, and participants were expected to send a code on that label every day after taking medication. So one of the facilitators for this technology was that it had privacy. As you see in the picture, the sticker and the blister pack. So that's all the participant needed, that blister pack and their cell phone, to be able to send the codes or the SMS every day after taking medication. And the other facilitator was that participants would receive an acknowledged thank you message after sending the SMS. And they felt appreciated and motivated because of this acknowledgement SMS they would receive every day. And thirdly, we found that in terms of age, the easy and the young found the labels, it was easy for the young and technologically savvy to use this label technology. Fourthly, the differentiated care support Nonto mentioned earlier were also facilitators, because if a participant missed the dose, they would receive an automated SMS reminder on the same day, reminding them to take medication before 12 midnight. If they missed doses for 2 to 3 days, a healthcare worker was expected to follow up with a phone call. If they missed doses for 4 or more days, a home visit was initiated by the community healthcare worker. So this differentiated support encouraged the participants to use the technology. However, there were several barriers that we experienced in South Africa as we implemented the label. So as reported by the label users, there were some individual label factors such as old age, illiteracy, and forgetting, which affected the use of the label. So they were not able to send the SMS daily as required because of these factors. And secondly, some of the participants did not have access to a cell phone. The project allowed us to enroll if participants were sharing a phone with a household member, but we found this challenging because sometimes the participant would take medication and the person they share the phone with won't be available. So they were not able to send the SMS. Some participants would have their phones damaged, lost, or stolen during the course of the study. So they were not able to engage with the technology. And we also experienced technical glitches, which were difficult to resolve. For example, there was need for positive airtime balance. So this SMS was supposed to be a free SMS, but some service providers needed patients to have at least a positive airtime balance for that free SMS to go through. It was not going to deduct the airtime, but they just had to have a positive airtime balance. Secondly, with some participants, the code was just not going through, even though they had a positive airtime balance. And there was need to change some phone settings for the people with TB, which was an invasion of privacy. Some participants were not comfortable with that. And in South Africa, just to provide context, we are having a challenge of scheduled power cuts across the country. So these power cuts affected network and phone battery charging, meaning the participants were not able to engage with the technology. Because of these the challenges, participants received excessive reminder messages, which led to irritation. There were some social harm reports which happened because of this, receiving excessive reminder messages, up to the extent that there was unintended disclosure. And as a result, there was also higher withdrawal of participants amongst the label users as compared to the smart pill box users. And because of these challenges, South Africa made a decision after engaging with various advisory boards and ethics to stop implementing the labels because it was not working for the population. So we just continued with the smart pill box. Over 90% of the participants switched from the label to the box. Only a few who were comfortable with the box remained with using the label until they finished treatment. But from that date, we stopped officially. No new users were enrolled on the label. So one of the facilitators of the smart pill box now, which most people were now using, explaining also Nonto statistics that in South Africa, 95% of the people with TB used the smart pill box and only 5% used the label. One of the facilitators was adequate counseling. So as I explained earlier on, it's important for healthcare workers to provide enough information to the participants for them to fully engage with the technology so that they have an understanding of how it works and the meaning of the lights that show on the smart pill box. And also participants reported features of the pill box being of great importance. The pill box was very easy to use. Even the old could use it across all the ages. It was just a matter of opening the box when the alarm buzzes. The alarm reminder was very useful. The reminder lights, for example, which reminded participants to go for a clinic refill visit. They appreciated storage. In South Africa, there's also high HIV co-infection. So other participants were even now reporting storing art treatment in these pill boxes, and their medication was safe. Participants reported that it was portable for some, and there was no need for one to have a cell phone when using this technology. Of course, it would have been great for one to have a phone so that they can receive the reminder SMSs or the phone calls, but the technology could still work for them without having a cell phone, which was important. And the long battery life was also appreciated, because if the battery was charged it was fully charged, it would last for 6 months, which tallied with treatment duration for most drug-sensitive TB patients. Yeah. The other facilitator was the patient-centeredness of the technology. For example, the people with TB would choose the convenient time for the alarm to buzz. It was not decided by the healthcare worker, but it was a time that was convenient for them. And there was also a change in the box size in one of the districts in South Africa, Cape Town. The DRTB participants were using a big box. It was like a shoebox, the size. And we got reports that it was difficult to carry. It was not user-friendly because of the size. So when we got that report, we engaged with the manufacturer, who now provided an alternative of a smaller box. So those who needed a smaller box were given that smaller box, and that just shows how patient-centeredness was important, listening to the needs of the people we are providing the service or the technology to, and acting should they have requests. The other facilitator was family and community support. We found from the people with TB, it was important for family members and friends to accept that technology so that they don't find the alarm reminder irritating. And we also got reports that family members would remind the participant to take their medication if the box rang when they were not in the vicinity. So there was a lot of reports on how family and community support were facilitators for engagement. And also, just as with the label technology, differentiated care support was a key facilitator. And in South Africa and also in ASCENT in general, we had community advisory boards in all the countries. So we would consult this board in terms of how best to deliver the digital adherence technologies. So our CAB comprised mostly of community healthcare workers leads who had experience with visiting these people with TB at their homes. So they had that community level experience. So they guided us on stigma, on how to reduce stigma. For example, we used to have bags written TB on them, and they advised us to start using plain bags to reduce stigma for the participants to carry the box in. And they also provided guidance on the wording of the reminder messages and motivation messages. So that was also an important facilitator, having advisors who had experience, contextual experience from home visit perspective. So there were also some barriers we noted in terms of engagements with the pillbox. One of the barriers was that it was not portable for everyone. Hence, some people with TB would leave the box behind when traveling for short periods. And during that time, they were not able to engage with the technology. So they would take out the medication and leave the box behind. And healthcare workers would not non-adherence, which they would change to manual doses after calling the participant. There were also reports of malfunctioning alarm and low battery. So sometimes the alarm would ring at the wrong time or multiple times, which was a barrier to engagement because other participants would now withdraw from the study because of that, but these were not many. And there were also complaints of low battery. This was especially among the DRTB participants who took treatment for longer than 6 months. So after 6 months, at some point, the battery would deplete and they would have to visit the clinic for the battery to be charged. And sometimes it was not done as quickly as expected. The other barrier was perceived stigma. Just to highlight that the stigma was perceived, none of the participants reported experienced stigma, but it was all in their mind. So because of this perceived stigma, some participants would leave the box behind when visiting or when traveling to people they had not disclosed their TB status to, because they feared that the alarm would draw attention or people would ask what the box is for and unintentionally disclose their TB status and get stigmatized, especially because TB is also related with HIV. We also found that the box was not easy to use for other participants in certain circumstances. For example, mine workers in one of the districts, Bujanala district in the northwest, it's a mining district, and some of the participants were mine workers and they were not allowed to take the box with when they're going underground. And sometimes when a participant experiences incarceration, they were not allowed to take the box to prison with, and that was a barrier to engagement. So we also had a chatbot WhatsApp platform, which was used to support participants who were on 3HP. So this was a WhatsApp-based technology. It had a user-friendly interface, which was a facilitator, and there was interaction with the healthcare workers to report side effects, which was also very important. So amongst the healthcare workers, some of the facilitators for user engagement was the ease of use of the adherence platforms we used, the adequate training of the healthcare workers, as emphasized earlier, buy-in from district coordinators, because they were now supporting the facility-based staff. For example, if you see in this photograph, we have a facility-based healthcare worker being supported by a district coordinator. So we found it very, very useful to get their buy-in so that they get to motivate and support the facility-based staff, especially also with the staff rotations. They were able to stand in the gap sometimes. Yeah. Also, remote monitoring convenience was reported as a facilitator. The technology saved their time and resources to do the direct observe therapy. They also appreciated that the technology allowed early intervention. For example, there were some participants who were non-adherent because of substance abuse or side effects. So this technology enabled healthcare workers to identify non-adherence early and then follow up using the differentiated care pathway, then refer these participants accordingly, for example, to social workers if they noted that there were these psychosocial issues, or referred to a medical doctor if side effects were the reason for non-adherence. And in 3 of the 5 districts, we had support from interns, which was appreciated by healthcare workers because there were times they could be busy with routine activities or they had to attend other trainings. So these interns were there to support, and motivation was also important for the healthcare workers in as much as it was important for the people with TB. So this was through site support visits and also regular meetings where they would share their experiences and resolve any challenges for them to continue implementing smoothly. Okay. Healthcare workers also faced some challenges with user engagement. For example, in some circumstances, they needed to constantly follow up with people with TB, which was time-consuming for them. This was caused by delayed adherence updates from boxes caused by the power cuts. For the label users, this was caused by SMSs not going through due to the reasons I listed earlier, or the participants not sending the messages. So non-adherence reflected on the platform, and the healthcare workers constantly had to follow up, which they found time-consuming. And there was also difficulties in contacting people with TB to confirm missed doses, because once there is non-adherence, the healthcare worker would follow up with the participants to get an explanation on why there was non-adherence. So if there wasn't reasonable explanation, for example, a participant reported that they left the box behind because they feared stigma when traveling, but they took the medication blister packs and they were adherent. Healthcare workers were able to manually confirm these doses. But in circumstances where they had wrong contact details from the people with TB, or they were changing numbers, or they were constantly moving, it was difficult now for the healthcare workers to follow up telephonically or through home visits. And some healthcare workers experienced logging in challenges due to poor network, which was exacerbated by those power cuts. There were also some time constraints to view adherence due to other commitments, especially in this district, Cape Town, where there was no support from the interns. So it was only routine-based staff implementing the study. So during the times where they were busy with audits or they had other commitments, there was none in there was no engagement with the technology, and staff rotations also affected engagement with the technology at the facilities until there was someone trained to take over. So these are two quotations from the success stories we had. One of the female TB nurses said, with this device, it's very easy, it's very quick, and unlike going to the file or to that book of mind checking, it's a long process. So here they were appreciating the convenience of this electronic adherence platform instead of manually checking TB patients' files. And this person with TB said, I love the alarm reminder to take medication and the safe storage. My medication stays safe in the box. So in terms of the role of healthcare workers in continued engagement, in South Africa, we found that motivation is very important. The people with TB need positive reinforcement during clinic visits. For example, by showing those who are doing well their adherence platform and just motivate them to keep on taking the medication using the technology, and also graduation ceremonies. So in Cape Town, they would have a graduation ceremony for people with TB who completed the treatment using the technology, which was also motivating. So in people with TB starting the treatment were also invited to these ceremonies, and they would be inspired to do the same and also reach this milestone. And we also found strengthened adherence counseling and providing adequate knowledge on DAT as an important role healthcare workers have to take to encourage continued engagement, and also reporting of technical glitches experienced by both healthcare workers and people with TB. This will ensure quick resolvement of these glitches to avoid frustration and now withdrawing from the technology. And finally, considering user feedback to increase patient-centeredness is very important. Everyone's feedback matters, both the people with TB as well as the healthcare workers. For instance, the labels were stopped in South Africa based on their feedback, and we ended up changing the box size in Cape Town based on feedback. So some of the lessons learned were that patient-centeredness is key. It's important also to train people with TB to charge the devices themselves. This could have avoided the glitch of depleted batteries and participants not being able to use the box because someone needs to charge they need to make a trip to the facility and someone needs to charge the battery for them. So it's important to provide participants chargers if they've got electricity and they can easily charge themselves. And that was also a request and recommendation from people with TB for the future. And it's also important to engage fully with service providers before implementing cell phone-based strategies. This could have also avoided this need for positive airtime balance. Motivation is important for both people with TB and healthcare workers to engage with the technology. TB focal staff need support, so it's important to train different healthcare workers, for example, pharmacy assistants or data capturers who can stand in if the TB focal nurse is busy. And also it's important to integrate with psychosocial services because this technology helped healthcare workers to identify some of the psychosocial reasons why participants were not taking medication. And it was important for them to now refer accordingly to social workers or psychologists. So it's important to integrate these two services. And also integration of the adherence platform with existing systems, for example, with TIA.net and EDR Web for DRTB in South Africa. So this will centralize the monitoring activities, and healthcare workers will avoid logging in from one platform into another if everything is in one platform, if possible. So These are my acknowledgements. Would like to thank United for funding the ASCENT project, the ASCENT consortium, and the Department of Health in South Africa at national, provincial, and district level, the TB focal persons and staff who implemented at the healthcare facilities, the study participants, the community advisory group, and the Aurum Institute ASCENT country team. Thank you.
Thank you, Tanya, for your presentation. Also to Nonto, thank you for your presentation. Are there any questions?
It is a surprise, no surprise to me that many users in South Africa, but I assume also elsewhere, preferred the box over the label. So what were the arguments to experiment with the label in the first place? Who would have been really benefited there? So if there's someone that can reply to that, the floor is yours.
Yeah, sure. So Nonto or Tanya, if you'd like to respond to that. Otherwise, I can also ask my colleague Jaap if he is available to provide some insight into that level of decision making for the ASCENT project. Nonto or Tanya, are either of you able to respond initially?
Oh, thanks, Ines. One of the reasons was that the label technology was cheaper than the box. So if it had worked, it would have been great to go with that one because of cost reasons. And it also needed to be researched for us to see if it works or not. To also provide alternatives. Yeah.
Yes, I concur with Tanya's response that the labels were just much cheaper to implement. It was just a matter of printing the labels and appending them on the blister pack for the patient. It would have benefited the department in terms of costs. But we did find a lot that patients really loved the box as well, even though it is the more costly digital adherence technology. But I guess the label would have been very beneficial because it's a very small cost to the department.
Yeah, thanks, Nonto. I think also in terms of the medication label, so South Africa is one country out of the 5 countries within the ASCENT project, and we see with some other countries that it is a technology that is perfectly viable as well. So considering Ethiopia, for example, where the medication label didn't have anywhere near as many challenges, and there was a population group that was sufficiently supported by the medication label and actually engaged with that technology as well. So I think it also depends a little bit on the context. And in South Africa, the integration was just particularly challenging. So it reduced the possibility of people sufficiently being able to engage. I'm going to hand over to Sijabu from Eswatini. And Sijabu is the PMDT focal person in Eswatini and has supported with the DAT rollout.
Thank you, Ines, for the introduction. Like I've been introduced, colleagues, my name is Sijabu Masina from the National TB Program of Eswatini. I'm the PMDT coordinator. Can you move to the next slide, Ines? Ines will be sharing on my behalf. Colleagues, this is my presentation outline. I will present on the country context, the inception of VST, the scale up to other regions, the implementation framework, supervision, challenges and lesson learned, and the way forward. Can we have a next slide, please? This is a background of Eswatini. Eswatini has got a population of 1.2 million, according to the last population census, and we're about to do another one, probably this year or next year. And Eswatini still is one of the 30 countries with a high burden of TB and HIV. And our incidence rate is 325 per 100,000 people. We are supposed to notify 3,900 cases. And our resistant and MTR incidence is 19 per 100,000, and we're supposed to notify 230 cases. The DRTP HIV co-infection rate is 72%, according to NTCP report 2023. We have got our TB diagnostic networks in the country. We've got 35 GeneXpect sites, which have 38 GeneXpect devices, 2 culture labs, 1 DSTP lab, including phenotypically LPA and TB sequencing, which is based in Bamani, and the other ones at Shiselweni. Then our TB service organization, we have got 151 accredited TB treatment units with 14 TRS sites. Then we've right now we have got electronic TB information system established, the CMIS. On the left side, we have got a picture of Eswatini with the decentralized 14 TRS sites. These slides is just talking about a brief completion treatment of DRTB from 2018 to 2023. I'll just highlight on the treatment success rate. From 2018, our treatment success rate as a country, we're at 74, then increased to 77 in 2019, 2020, 81, 2021 and 2022, we suffer a regress due to COVID, right? But right now in 2023, we're in 84%. Our death rate, we started around 15%, around 20 at this point in time.
Sijabu, are you there? Sijabu? I think you're muted.
Okay, I'm back. Thank you. My apologies. My network is not good.
No
yes, our death rate currently were at 8%, yet we are not even reached the WHO target of 5%. Our loss to follow up and not evaluated were at 4%. On the right side, we have got our DR outcome by region. The highest region is Shiselweni by 97, followed by Ho 96, then Lubombo 85, Manzini at 76. Next slide, please. Inception of video supported treatment therapy. It was implemented by MSF at Shiselweni region in March 2020. With the main reason was to reduce the risk of people with their TB being exposed to COVID-19 by their treatment supporters. This was a pilot study by MSF, local healthcare providers, and we were using a platform, Show Adhere. This was a customized platform to Eswatini context to accomplish the virtual for people with their TB. Then this Shiselweni, it's marked on the map. Shiselweni was being supported by the longest time by MSF. Can we have another slide? We are continuing with inception. Following the following documents were developed before the VOT or VST was implemented. There was a VOT operation, the SOP, which included the patient consent form, cell phone contract, and the video recording instruction sheet that guided the enrollment of people on VST. Smartphones were provided by MSF. These were handed back. Handed back by the patient at the end of the treatment. The cell phones came with a preloaded data with the platform uploaded in the cell phone. On the left side, it is the picture of the cell phone with the platform. Then there is the calendar in the smaller cell phone. The green, it means the client sent the video, and the video has been viewed by the healthcare worker, and the video has been commented. If there's a red, it means the client didn't send a video, or the yellow, it means the client has sent the video, or the healthcare worker has viewed it, and there are some comments. Probably the video is not visible enough, or doesn't have an audio, or the client or the healthcare worker haven't yet viewed the video. Can we have a next slide, please? Then, then we scale up to the DST to other regions. The NTCP used the lesson learned from MSF pilot for funding advocacy for more funding to scale up VOT to other regions. The country managed to get support from Global Fund for the 3 years, from 2022 to 2024, and we even continuing to 2026. We were able to procure 14 laptops for the 14 DR sites and 105 smartphones through the Global Fund. Then the readiness assessment was done to the 11 DR sites in the 3 regions in preparation for the VST implementation. The main reason of this was to empower the clients to be in charge of their treatment. Moreover, to maintain the confidentiality the client will need in their treatment without using a treatment supporter. And with that will be only the healthcare worker will be in contact with the patient. Can we move on to the next slide? The following documents were developed to assist the enrollment people with the TB in the VST. The eligibility criteria. This is a long document. I just pick them all the important point. All people with DRTP were eligible, including children. We didn't want to leave our children behind, and patients who reside in the area with an MTN network coverage. Patient on BPAL, modified shorter regimen and longer regimen will be included in the VST. And we even included people with mental health condition as they are, the healthcare worker will determine by using the mental health status evaluation if that client is fit to use the cell phone. Then we have excluding criteria. A patient who are on INH mono, especially on RZE, they won't be eligible, won't be initiated in VST. And patient who opted out that he or she doesn't want to be part of this innovation, he or she won't be forced. Then we have got the contract. The client the healthcare worker will read the contract word by word, explaining every detail in the contract so that the client understand what is he or she expected to do while is still in VST. Then the client will sign that contract at the end of the session if the client agrees to be part of this innovation. Next slide, please. Okay. Okay. Then we had a national training where healthcare workers and implementing partners were trained and with the tools that were developed. And we had a site visit where we distributed the laptops to all the 14 DR sites, and we left 2 cell phones with prepaid loaded data in preparation of the enrollment of VST. And while we were doing the site visit, we even trained more healthcare workers on site. Can we have another slide, please? The supervision, on-site supervision, the healthcare worker, which is the nurse, screening officer, and adherence officers, all those personnel were trained, will view the video, comment on the platform. They will comment if the video it's clear and audible enough, and they will comment if the client has reported an side effect. Then they will call the client and give the instruction what to do. Then we've got the regional TB doctors, facility managers, and regional coordinators. They monitor the implementation of the implementation at the facility. Then the central supervision, it's the national staff, the PMTT team. They have got access to view the progress of the platform. However, they are not allowed to comment on the platform. If ever they noted any hindrances or any, they will just call the facility for further input. Next slide, please. Then we have got challenges and lessons learned. I will start with the challenges. There is a competition between VST and treatment supporter stipend. Before VOT was implemented, our clients were being monitored by treatment supporters, and the treatment supporter were receiving a stipend of 500 emalangeni. So in this case, once the client is in VST, the client won't receive the treatment supporter, as he or she will be given the phone with data. Some patients refused to return their cell phones, as it was stated in the cell phone contract. After the client completes treatment, we explain in the contract that we will take back the phone for continuity of care. But some clients they don't return the phones. Most of the phones, like the fellow colleague has just alluded, the cell phones get lost. Most of the cell phones, when they return with cracked screens. And in the country, we've got this area, especially in the rural areas where the MTN coverage it's not good. So those clients are not able to be implemented in the VOT. Then lessons learned. People with TB should be given more information on VST and advantages of being in VST in combat with treatment supporter. Our cell phones should have skin guards and pouches stored for protection. Then people with TB were able to be in charge of their treatment, as no treatment supporter will remind him or her. The client will take full responsibility of his treatment or her treatment. Then the client will able to be in contact with the healthcare worker on daily basis in case of adverse event, because whenever the client has a complaint, while recording the video, he will raise his or her concern or her problem. The nurse or the healthcare worker, while viewing the video, he will see the client is complaining of this and that. Then the nurse will call and they will able to communicate, and will able to to reach out immediately for those who will need a potential potential action, and able to reach immediately those who may have a potential to treatment interruption when the video is not submitted. So when you don't see the video, you're able to call the client. I didn't see your video. What's the problem? Probably the client won't able to record the video because that day maybe he or she's bedridden. So then those means that they will be done so that the client can be taken to hospital, or the client have got any other social issues, so that as ministry can able to interject before the client interrupt treatment. Next slide, please. The way forward as a program, we will add another digital adherence technology, the smart pillboxes in both DS and DR facilities. Smart pillboxes will be enrolled to clients who with DRTP who are not eligible for VST. In addition, people with DSTP in the DR 14 site, then later will scale up to the other BMUs. The procurement of smart pillboxes was included in the Global Fund grant making, and we are hoping that we will be accepted. Can we have another slide, please? Thank you, colleagues. Before I hand it over to Ines, I would like to pass my acknowledgement to the MOH and NTCP staff, the RTP facilities who were with us from the start, the implementing partners. I won't forget our Global Fund who are sponsors. Thank you. Back to you, Ines.
Thank you, Sijabu, for the overview of video-supported treatments in Eswatini, and also for your plans going forward. Thanks for that. I'm just having a quick look at the chat to see if there are any questions. Are there any questions?
We have a question from Svetlana, and says, my question is related to the sustainability. Is there any plan for the, I'm assuming it says use, for the use of VST of the video support treatment after the project ends? This is specifically to Sijabu, I'm assuming, right?
I'm wondering about that. So yeah, Sijabu, I mean, of course, please feel free to provide insight into how you, or whether you plan to continue with video supported treatments once rolling out the smart pillbox, or just provide some more insights into that.
Thank you, Ines. Yes, we will continue with the VST even when we are rolling out with smart pillboxes. Like I've stated, all those clients who are not eligible for VST will be initiated on smart pillboxes. Those two technologies will run concurrently. Thank you.
Great, thank you, Sijabu. Is there anybody else with any burning questions? Shri, I see that you have videoed yourself.
Thank you for a wonderful presentation. Very insightful, very useful. I'm from India, based out of Bangalore, a city located in South India. So I was a part of the evaluation of this digital adherence technology. So I'm just curious in terms of, especially in your setup, if there is a private sector which provides the TB services, have you tried to use this technology among the private practitioners' patients? If so, is there a difference between the public sector patients and the private sector patients? Over.
Great, thanks for your question, Shri. So I would like to ask Nonto, Tanya, and Sijabu to provide some insights there. Should we start with someone from South Africa?
All right, thank you very much, Ines, and Vijayashree. So in South Africa, we only implemented in the public sector. We have not tried it in private. I think that's our response. Yeah.
Just a follow-up question. Do you think there is a need for us to check this intervention with the private sector patients? Is there a utility?
So most patients really who undergo TB treatment in South Africa undergo the treatment through the public sector. Even the private practitioners, if they really suspect TB, they usually refer to the public sector, the patients to go to public for testing. So we don't really have a high number of patients who are undergoing TB treatment under the private sector. However, there are many recommendations for training, doctors in the private sector on TB management, and making them really part of the fight against TB. But currently, the bulk of TB patients undergoing TB treatment do so under the public sector. And it's mostly because, that treatment is free, whereas the public doctor does not really want all that workload of dealing with TB. So maybe it will change in future, as more TB private doctors are being trained in managing TB.
Thank you.
Thanks, Nonto.
Okay.
Sijabu, did you want to say anything?
Yes, Ines, yes. In Eswatini, only drug susceptible private practitioner, only drug susceptible is offered on the private practitioner. So when we are implementing the smart pillboxes, we will involve those facilities in the on those private practitioners. But on the drug resistant side, all the facilities are public, are governmentally owned. So yeah, but it's food for thought. But on our side, we still are engaging one private to offer DR. We are still negotiating with them. If they agree, they will implement even the DST. Thank you.
Thanks, Sijabu. And then Shri, I see one last comment in terms of the ASCENT project, that when ASCENT was rolled out under, sorry, not ASCENT, when the first DAT projects under KNCV, which were rolled out under TB Reach Wave 6, 99 dots was piloted within a number of private facilities in the Philippines. Just to kind of close off this webinar, as you know, this is the third of a series of webinars that we're hosting under the Global DAT Task Force, and our intention is to host one webinar per month on the last Wednesday of the month. And so we try to get countries that have experience in implementing DATs to explore various topics within implementation. So with this particular technology, it's not a one-size-fits-all approach, but really to stimulate that cross-country learning so that we're able to provide support to other countries that are in the planning process of implementation or who are already implementing but face some challenges. So this is really a way that different countries can learn from each other. And okay, we are on a little bit over time. So I want to close off the webinar and say thank you all very much for joining. Thanks for participating and for your questions. You see here the email address of the DAT Task Force Secretariat. If you have any questions, please feel free to reach out to us. The Secretariat is hosted at KNCV Tuberculosis Foundation, and you can reach us on secretariat@tbdigitaladherence.org. And then secondly, the QR code on the right-hand side, but also the web address at the bottom there, tbdigitaladherence.org, is our website for the Global DAT Task Force. And there you can find a lot of information related to digital adherence technologies, comparison of the different technologies, as well as a lot of training materials and resources that you can use for implementation. And in addition to that, we also have a page on there dedicated to the Learning Hub, where you can watch recordings from previous webinars and use that for your implementation planning. So look out for the next webinar, and we look forward to seeing you then. Thank you.